Hi, I'm Dr. David Rubin, a pulmonologist and medical director and respiratory R&D at GlaxoSmithKline. I'm presenting on predictors of pneumonia on routine chest radiographs in patients with COPD, post-hoc analysis of two one-year randomized controlled trials, a publication written by myself and colleagues at GSK and Mayo Clinica. Readers of this journal know that patients with COPD are at a higher risk for pneumonia and pneumonia-related death compared to patients without COPD. A pulmonary quote-unquote dogma is that anatomic changes to the lungs make them susceptible to pneumonia, and therefore we speculated that anatomic abnormalities identified on a chest x-ray could predict pneumonia risk. We found 5 observations on a routine chest x-ray that increases the odds for developing a pneumonia over 1 year when compared to COPD patients without these findings. In order of the highest to lowest risk, these are elevated hemidiaphragm, thick tracheoesophageal stripe, narrow cardiac silhouette, calcified pleural plaque / mid-chest pleural thickening, and prominent pulmonary artery. Now, this first example is a chest x-ray of a normal COPD chest x-ray, quote unquote. Note the flat diaphragms on PA and lateral. Here is an example of an elevated hemidiaphragm, a radiographic sign with about a 7-fold risk for developing pneumonia. We speculate that elevated hemidiaphragm incites loss of lung volume and may result in inability to clear mucus and microbes. This next lateral film shows arrows indicating a thick tracheoesophageal stripe, conveying more than a 4-fold risk for pneumonia. A thick TE stripe can indicate esophageal disease associated with GERD, and hence increased aspiration risk as a cause for pneumonia. This next slide, a narrow cardiac silhouette, the classic COPD radiographic sign indicates a 3-fold risk for pneumonia. We found significantly lower FEV1 in patients with narrow cardiac silhouette compared to those without this finding, and believe that when mediastinal structures are rotated, it reflects COPD severity of hyperinflation, and it's known that pneumonia risk increases with increased airflow obstruction. Also with the 3-fold risk of pneumonia is the calcified pleural plaque / mid-chest pleural thickening that could reflect asbestosis or prior pneumonia, entities related to increased pneumonia risk, possibly indicative of an underlying abnormal lung substratum ripe for infection. And last, a large pulmonary artery shadow, which predicts a nearly a 2-fold risk for pneumonia, and patients with this sign tended to have a lower FEV1, and we speculate that the large pulmonary shadow reflects disease severity, wherein hypoxia could be related to a large pulmonary artery shadow indicative of pulmonary hypertension. Because this is a post-hoc analysis, we can only hypothesize that these anatomic changes are closely linked to pneumonia risk. Ideally, prospective studies monitoring these findings would be needed. We hope that readers of this article will be stimulated to monitor these abnormalities prospectively in their COPD patients and determine the true relationship between these chest x-ray findings and pneumonia. Thank you for your attention.